My name is Margo Edmunds. I'm from AcademyHealth. I have the pleasure and the privilege to be the co-PI on the new Kresge Foundation grant for the National Interoperability Collaborative, which you've been hearing a lot about. This panel is entitled HHS Today, Tomorrow, and Beyond, Accelerating Progress in Changing Times, and it was designed to follow the federal panel. So I think we heard a few comments from our federal colleagues, some of whom are still with us, about the importance of what happens at the state and local levels, not only in government, but also in the private sector. We heard about new business models. We talked about helping produce data sharing guidance, some of the things that the collaborative can provide for ONC and for other agencies and looking for best practices. We heard that it's easier to overcome the opioid issue and a lot of other complicated issues at the local level, that we need better tools for people in communities. We heard about really needing, from Chris in particular, about needing to see a cultural shift. And so that came up at the last of the federal panel. That's a lot of what this panel is going to be discussing. We also heard all y'all need to hold us accountable. So that's a lot of what this panel is going to be about, is about really getting into the real world at the state and local levels. So let me first introduce the panelists. We have Annette R. Kellyan. They're sitting in the order in which they appear on the slide, who is from Kaiser Permanente. She's a pharmacist originally. We have Kate McAvoy, who's an attorney, who's here representing the Connecticut Department of Social Services. We have Uma Ahluwalia from Montgomery County, Maryland, just up the road from the Department of Health and Human Services. Rasu Shrethra from UPMC, who is also here in his role with HIMSS, which he will tell you about. And our responder will be Tom Novak from the Office of the National Coordinator, who is here in a kind of a unofficial role, I guess. Not officially representing ONC, but also, giving us a lot of information about ONC. So what I'd like to do is start by asking each panelist to take a few minutes to introduce yourself in a little more detail, talk about your portfolio and your responsibilities so we know what your perspective is. We have two folks from the state and local public sector. We have two private sector folks, and we have one federal government representative. So Annette, would you start us off?
Thank you. Oops. Can you hear me? Okay. Thank you, everyone. Good morning. So my name is Annette R. Kellyan, and I work for Kaiser Permanente in the Southern California region. Kaiser Permanente is probably one of the largest integrated healthcare systems in the country. And we're in about 9 states, I believe, and we have 6 or 7 regions that roll up to what is known as Kaiser Permanente. And the reason I wanted to mention the integration piece is that's sort of important to the conversation here today, is that we own our physicians, well, we're partners with our physicians, our lab, pharmacy, and multitude of services. So we have data that we can reach on any and each of all of our services. I serve the organization in a capacity of a new title. It's Executive Director of Medicare Strategy and Care Delivery. And my primary goal is around meeting the needs of our high-resource, high-need patients, our most vulnerable of our patient populations. And one of those areas is really addressing social determinants of health. Kaiser had some systems in place, but we're still at our infancy in developing reliable systems to address not only the medical needs of our patients, but the non-clinical and social determinants of health. And that's the work that I'm involved in with various partners in the community.
Thanks, Annette. Kate, you're up.
Good morning. I'm Kate McAvoy. I'm the Director of the Division of Health Services for the Connecticut Department of Social Services. Today I'm very privileged to be representing our Commissioner, Rod Bremby. Very much regretted not being able to attend today because of a family event, but this is a very high-level set of priorities for him. We are a multi-purpose social services agency. We serve over 1 million Connecticut citizens with core services including Medicaid, SNAP, and TFA. We are in Connecticut not an omnibus model as has been adopted in other states. However, we have sister departments that span a range of other health and human services needs, including mental health and addiction services, child welfare, and also individuals with intellectual disabilities. So we have not taken that kind of consolidated approach, and that does inform and also also, in some cases, make more complex our agenda around interoperability and commonality in terms of the use of data. I'm here with a multidisciplinary team that is led by our Deputy Commissioner, Kathy Brennan, really representing all of the facets of the work that we're talking about linking and synthesizing here. Medicaid is my domain, but we also have representative from social work, from the community services block grant area, and also taking into account how those features interrelate. I will say my agenda under the Commissioner's leadership in Medicaid really has been to epitomize our mission, which is around wellness and economic security. So we have we hope done our best to transcend a unique focus on medical care, to really examine the features that contribute to wellness, and also have been able, as have many other expansion states, have been able to link the provision of Medicaid, especially to individuals who historically were not eligible, to economic security, coverage in its own right, representing security, offsetting uncovered medical costs, but also security around the anxiety that comes associated with lack of coverage or inadequate coverage. So those are constant themes for us, wellness and economic security, and that informs our policy rationales.
Thank you. Thank you, Kate. Uma?
Sure. Good morning, everyone. So I'm Uma Aluwali. I'm the director of the Department of Health and Human Services for Montgomery County, Maryland. And as the name says, we have health and human services, so we're an omnibus agency, is that what you called it? So our enterprise consists of aging and disability services, behavioral health, children's services and income supports, public health, and homeless services. So it's pretty comprehensive. We have, over the last 10 or so years, we've been integrated for about 22 years now into a single department. For the last 10 or so years, we've really been working on both the practice of integration, the policy, and the technology as it supports integration. And just this past March, we fully implemented our electronic integrated case management system. We've already implemented our electronic health record, the master client index. And so a lot of the conversation that's happening over here, I've been with stewards coming for 12 years now, so I've walked the journey with Daniel and others, and I think we're in a place now where we can talk about this work and actually have some more than stories, right? We actually have results. We've integrated, and our practice is integrated, and so there's a lot to talk about here. Thank you.
Thank you. Rasu?
Hi, good morning, everyone. A pleasure to be here, and a pleasure more so to follow the rockstar panel that preceded us. I think it was really refreshing to hear directly from the horse's mouth, so to speak, with regards to where HHS is going at a very macro level as well as a micro level as well. So my name is Rasu Shrestha. I'm not an orthopedic surgeon. I am a radiologist, however, by training, and I'm the Chief Innovation Officer at UPMC. So UPMC is a pretty large payer-provider organization, an integrated delivery financial system, as some would call it. We're about 62,000 employees. We're a $14 billion healthcare organization. On the provider side, we have about 25 hospitals with 3,800 physicians. And on the payer side, which is really interesting, this yin and yang of the payer and the provider. On the payer side, we have a network of about 3.2 million members and about 11,500 physicians across the network. And as we're really talking about the move in the industry of volume to value, what's interesting is I see Pittsburgh and Western Pennsylvania and the work that we're doing, as well as some of the others in that space, as being ground zero for accountable care, where there are lots and lots of activities happening around value-based healthcare. And one of the things that we're really trying to push forward is to say, how do we make sure that we're able to leverage the power of partnerships? Because I do believe that the future of healthcare is going to be built on the shoulders of the strongest of partnerships. And that's what we're trying to leverage here with Stewards of Change. I'm also the chair of the HIMSS Innovation Committee. And I just got pulled in as the co-chair for Academy Health's Health Data Palooza 2018, so I'm really excited about that, Margo, thank you. But partnerships, I think, is what's really going to drive the future of healthcare, and I think that's what we're here to talk about. And how do we bridge, when we talk about interoperability, not just the challenges that we've all sort of dealt with in the health IT realm in the last 20-odd years, but bridging that to the specifics of human services and making sure that we're able to really navigate the specifics of not just the challenges within the bricks and mortar hospitals, the walls within the hospitals, but where the patients really live, their zip code being perhaps a greater deterministic factor of outcomes than even their genetic code. That's the truth. That's the reality of where we are. And the common denominator in how we're trying to drive innovation forward at UPMC is not just to focus on information technology and data exchanges and standards, but really to focus on the human aspects of healthcare. How do we humanize the process of healthcare, whether it's around physician behavior, physician burnout, clinicians in general, patients, consumers, behavior change across the board. So we'll talk more about that, but it's a pleasure to be here. Thank you.
Thank you. Tom?
Thank you. So I guess I'm only unofficial in that I'm not just ONC. I am also CMS. And my apologies to any of you who were hoping to see Jess Khan. I am I'm the poor man's Jess Khan here. Does not make me feel bad.
Don't tweet
that. I'm always, this is literally probably the 7th or 8th thing I've done.
She's just having more fun.
Yeah, she's in Mexico right now. So what I work on the state Medicaid agencies and helping them with the system dollars to do the things that we're talking about today. So as we get these ideas, and your ideas a lot of times are just the business need, which is, I think, the CTO earlier sort of made that point that we begin with the business need. We want to enroll people in Medicaid and SNAP at the same time, or we want to have a PDMP that pushes an electronic notification to a social worker to say, that a particular patient showed up at a particular pharmacy with, at the wrong pharmacy, or something along those lines. So you have this business need, this thing you want to build at the state level, and then what I like to do, as part of my role, is help the states. Okay, how do we pay for that? What's the right bucket of money, from the federal perspective? How do we go through aligning it with the goals tied to that particular bucket of money? So it's there's a laborious process. It's a lot of drudgery, but we can then help the states actually build the things they want to build, leading with the business case. So I try to translate the alignment goals we have here today with, okay, how do we use the Medicaid system dollars to make those a reality? So we have a lot of one-on-one conversations with states as they say, here's what we want to do, here are our priorities. Okay, how can we make it happen from a state Medicaid point of view, and how can we support it with Medicaid systems? Because Medicaid systems care about Medicaid providers and Medicaid patients and making these things happen. So that's sort of where I jump in. So I sort of have a tendency to listen to all of these stories and say, okay, you could use this particular bucket of money in this particular way, and this would work, but we got to talk to your state Medicaid director or your state Medicaid stakeholders and whatnot. So that's sort of where I kind of like the responder role, because then I can sort of riff off of this a bit. So thank you for having me.
Absolutely. Right person, right time, right place. So for our next question, I'd like to ask everybody what their top policy priorities right now, and I'm going to kind of turn this upside down a little bit and start with the private sector. I'm going to start with the two health systems representatives. I think Rasu is going to kick us off, and then Annette, and then we'll hear from the state, and then we'll hear from Uma, and then we'll hear from our responder. So Rasu, maybe 3 top policy priorities for UPMC?
Absolutely. So especially in the trying times that we live in today, where we're all mandated to do more with less, it's really important to prioritize. And so I'll set this by contextualizing what those priorities are, where those priorities live. And the context here really is, if you look at where health IT has brought us in the last 20 plus years, it's really been in this journey of moving from analog to digital, paper to paperless, film to filmless. And we're in this digital reality today. But at the same time, what we've been doing for not just the last 2-3 decades, but really for centuries at a time, is we've been focusing on essentially surviving, right? This notion of sick care is what the healthcare system today is, that's the primary focus. And where we are at UPMC as a payer-provider system with some of the facets of what I mentioned earlier is how do we not just focus on sick care, which is absolutely important, and we're doing lots of great things in that realm, but how do we move the conversation from sick care to also well care, where the focus becomes not just on surviving, but on thriving. And what we've seen as an integrated delivery financial system, that when you focus, even if you focus with all of the information technology and machine learning and all the expertise that we're bringing to the table today around precision medicine and big data and all of that, if you focus on the notion of curing illness, hence surviving, it is still going to be cost acceleration. And when you start focusing on thriving and wellness, it's actually cost deceleration as a system. So with that, the three priorities for us, number one really is connecting the dots. And I know that phrase was used earlier in the panel session, so I had a little smile when that phrase was used. But that has been our priority for the last decade that I've been in Pittsburgh. I moved from Los Angeles to Pittsburgh, and one of the things that we've been trying to do in UPMC is to connect the dots across the many silos of information repositories that oftentimes shackle the data in their proprietary formats. And we have a best-of-breed strategy with multiple electronic medical record systems across the board. So connecting the clinical data together with interoperability, but not just with clinical data, but claims data and cost data and purchase data and behavioral data and outcomes data. And more so in the last couple of years, also focusing on the social determinants of healthcare, social data, so data around zip codes and where patients live, and a lot of the CMS data that's available out there. So that's sort of our number one priority. Number two really is in data liberation. And that phrase also was used earlier, and that's wonderful. And one of the things that we're trying to do on our own really is to liberate that data, basically lift that data and untether it from the silos of repositories that they essentially come bundled into, right? And what we've done is we've managed to untether that data. We have what we call our DLP, our Data Liberation Project. And we've then managed to put this on a bed of a next generation FHIR-enabled, so FHIR is an HL7 standard with open APIs that would then allow for us to create a set of solutions that really push value-based care forward. So data liberation is a big initiative for us across the board. And then the third priority for us is behavior change. So it's one thing to have data, and data really is liquid gold. Data allows for you and affords the ability for you to really have insights into the specifics of the decisions that you make. But it's really moving from data to information to knowledge, but putting that knowledge back in an actionable way at the point of decision making. So actionable insights is important, but it's not just about that. It really is about behavior change. So that's been a big focus for us as we look at these newer care models, as we look at value-based care models in terms of things like patient-centered medical homes, in terms of things like where you have cost sharing and care collaboration that goes well beyond the specific silos that we're used to today, as we go out into the community and really look at health services and really focus on outcomes and satisfaction and things that are a lot more meaningful than what we've been focusing on in prior years. And we're bringing in behavioral experts to actually enable that level of behavior change, both in terms of operations, in terms of clinical, as well as on the patient/consumer side.
Thanks very much. Big goals. KP?
Sure. Actually, very similar.
Yeah, I was thinking the same
Very
thing, yeah.
similar. But I'll just approach it a little different angle that we're, the buzzword that we're using within Kaiser around sort of our policy and what our goals are for the upcoming. But the word is affordability. A family of four, a cost for a family of four insurance is, I think now, the last figure I heard, $26,000 a year. I don't know about any of you, but I'm in the top 4% of an economic, in terms of my income, and I don't know if I could dish out $26,000. So that's a huge burden that we have on our families. So our goal is really around affordability. So Kaiser's mission statement is providing high quality and affordable care to the members we serve and in the community in which we live. So really taking that mantra and then distilling sort of what we look at. One of the first areas probably to highlight, and I think, Russell, you were probably getting around to it, was around drug costs. We're very concerned about the escalating drug costs. And the Hep C drugs are one, where it's cost of a Lexus and even more, maybe a Tesla, to treat Hep C. And that's great. We're able to eradicate a disease, but does it really need to cost $80,000? And the other one is, I think all of you are probably familiar with, are EpiPens, some of the generics, that doxycycline. I'm a pharmacist, so this really gets to my angst here. Around some of the cost escalation we've seen with some old drugs that we knew. Narcan, I mean, I think the whole discussion today was put Narcan in everyone's hands who need them, but it's about $300. And I can tell you as a practicing pharmacist, Narcan costs less than $1. So it's deplorable that I know, blood pressure's going up. But, that's not the intent of this. There is, and it's fortunately it costs less. It'll cost and lifestyle, yes. But it's really looking at drug costs and escalation of that area. But the reason that's important is you all know we have finite amount of dollars for healthcare that we, so Kaiser is a member organization that we get. So if we're having to divert those dollars to drug costs, that takes away from our other needs as well, such as investments into innovation, investments in data, and other things that we need to do. So that's a huge area of concern for us. And then in terms of the data piece, one of the things I'll add is that I have a colleague who would say the cure for cancer is in the Kaiser databases. And the reason he would say this is we have 12 million members, we have data on almost everything. We don't have social needs, but we're getting there. So the cure for cancer, and essentially for anything else, is probably in our databases. But imagine the power if we could augment that data with additional information. So we are working on doing some predictive analytics and putting the right type of data into the hands of people that need to make those changes. So our physicians leveraging the electronic medical record and getting the right data for them to help drive change, and also our members as well. We have continuously working on using the digital platforms to engage them in some behavioral changes that will help, again, come back to the word I used, affordability, really driving the affordability agenda.
Thank you very much. So now we'll go up the road. Well, actually, you flew across the country to get here. I think I'm a Mid-Atlantic Kaiser member, so I think of it being local. But let's hear from Connecticut, Kate.
Yeah, so it's very interesting to follow such forward-thinking and sophisticated systems in their prioritization of issues. I wanted to take a few moments to focus on, briefly, on 3 priorities for Connecticut: integrated eligibility platform, use of a value-based payment initiative to link medical and social services, and finally, cross-data set matching in support of policy priority development. Those are my focus areas. And I'd like to start by saying there's 2 major enabling features that have undergirded those efforts in Connecticut. The first is the tools and resources, many of the tools and resources embedded in the Affordable Care Act. And I want to acknowledge particularly Jess and Tom, the amount of capitalization from the federal government of these efforts around integration, both from the standpoint of the 90-10, which is a very fundamental change in terms of the ability, the wherewithal to bring these systems forward, but also the integrated authorities under the Affordable Care Act that have purposefully brought the federal policy agenda emphasis to really marrying up these points and to emphasizing care coordination in support of individuals who are not just the sum of their parts, looking at this from a whole person standpoint. So that is a major enabling feature, those ACA resources and the integrative authorities. Another more local enabling feature for us in Connecticut is we, in a departure from most other states, are now self-managed Medicaid program. We do not use any capitated managed care arrangements. So we're self-insured, we're managing our own care delivery and value-based strategies, and probably the most important derivative of migrating away from capitated managed care was that we have been able to develop a fully integrated claims data set for the entirety of our Medicaid claims, which has put us in a position, a superior position to any prior point in history in terms of intelligence about the patterns and the usage and what we can do to better enable supports for members in Connecticut Medicaid. So those are the features that I think have galvanized the work of these 3 priorities. First, our commissioner has made it a top priority for our agency to modernize and to streamline the process through which members approach and get connected to services. This has historically been very fragmented in almost all states. Some states and certainly counties are far ahead of us, and I look forward to hearing from Uma about her arrangements. But really, there was an effort to say not only are these tremendously antiquated systems, our COBOL-based system was over 25 years old and no longer even able to be supported by people who were coming back out of retirement, but really the features of synthesizing the programs so that we would reduce burden on people, reduce the affirmative need for documentation, and also marry up resources with, in Connecticut, our newly constituted our health exchange, Access Health Connecticut. And CMS really led efforts and really inspired and incented and required states to bring those strands together in a very purposeful way. We are on an evolutionary curve with that has first integrated a platform around the major safety net programs and will radiate out across our peer agencies to encompass other critical supports, for instance, WIC, so that we continue to make that as streamlined a process as is possible for individuals. I also want to point to the value and utility of the kind of automated documentation of eligibility that was also embedded in the exchanges. We don't often talk about that, but reducing that and optimizing the use of already existing federal data has been tremendously transformative also. So integrated eligibility is our first priority. Our second priority in Medicaid in particular, acknowledging the great observations of all that have come before us in this session and many other sessions, really around the central need for careful and thoughtful coordination of services and supports for Medicaid members across all domains, recognizing again that there are whole people with a multiplicity of needs. We started our kind of central seat of our care delivery reform was a person-centered medical program that married up multidisciplinary practice coaching free of charge to practices that with a predominantly pay-for-performance model. We knew that in our case in Connecticut, we needed to help practices come along from a relatively naive standpoint of readiness for care coordination embedded within the practice, and also moving along the process of acclimating to and becoming more sophisticated in the use of data, and also moving toward capacity to assume risks. None of those were at an advanced point of development in Connecticut. So we came along that curve with PCMH and have migrated that model just this January to implementation of an upside-only shared savings arrangement under which we have built upon the core features of care coordination in PCMH with enhanced care coordination features, behavioral health integration, class standards, and also disability competence, an area we found a lot of deficits in. Really building on that and also requiring the entities with which we're in those shared savings arrangements to have formal relationships with social services organizations, feedback loops, and really informing. We've also involved involved on a very purposeful basis our statewide integrated 211, which is operated by United Way in Connecticut. Their very sophisticated 211 system that may interest you to learn is already embedding in EHRs in some targeted areas of Connecticut. So bringing those things together to really, not just talk conceptually about integration and social determinants, but really knit that together from a very practical standpoint. And I'll wind up by saying our third priority is really taking the lead from much more sophisticated states that have moved along this curve ahead of us, like the state of Washington, to start doing some cross-data set matching. Our inaugural effort has focused on comparison of Medicaid claims with homeless management information system. Another enabling feature is we have an fully integrated statewide HMIS system in Connecticut. I understand California actually has probably over 100 distinct HMIS systems, so that's a whole nother challenge in terms of knitting those things together. But bringing that data together to build on the experience in two strands of work, our state-funded supportive housing agenda, and also our Money Follows the Person program that has demonstrated over a longitudinal basis the fundamental feature of housing stability is that it contributes to good health outcomes. You can't engage in your health goals unless you have stable housing. So bringing together that data matching, that's our inaugural effort, and really want to be the sort of vanguard in Connecticut of that as the new norm in policy prioritization. Thank you.
Thanks, Kate. Uma?
Wow.
Yeah, I know, it's quite a lot.
Can you
quite a
absorb
lot
all
of-
that? So when I hear the private sector speak, I feel like, oh God, we have so much ground to cover. And then when I hear the state speak, I feel like, oh God, we have so much ground to cover. But on the flip side, our size is small enough and manageable enough that we can actually do things and show results, right? So our CIO is here, our Chief Operating Officer is here, and for both of them, we wouldn't be here without their many efforts. The department has sort of three goals, right? Those goals are self-sufficiency, safety, so when you think about child protective services, adult protective services, safety and protective factors, and then health and well-being. And so in order to achieve those goals, we've been involved over the years in so many initiatives, right? But there were 5 key priorities for the department over the last 10 years, and we've stayed very consistent on those. Building an integrated practice agenda, so what does it mean across our enterprise to integrate? So if you took a person who's homeless and who has health conditions or behavioral health and lots of other things going on, how are we integrating? If they have children in their household, what does integrating the data really look like from a frontline practice perspective? Similarly, an adolescent who's pregnant. It's not just the public schools that are involved, it's the human services piece and the healthcare piece. So I could go on. I mean, we really picked, you talked about use cases, we picked use cases across our enterprise to build the practice agenda, the practice model for integration. The second thing we were focused on really was the interoperability piece, right? Building the technology modernization agenda that will help us then leverage the data across systems. And one of the really cool features in our new system is a screening for needs questionnaire that's part of and built into our intake process. And so we ask people up front, what do you need? With the idea that we're going to move the services into a more prevention agenda up front. And as we're talking about all this, what does that do, right? This is a huge issue. It moves the utilization of those services up front. So you really have to reorder your budget in a way that's going to enable you to actually deploy more resources to the front end of the system. Where are those resources deployed right now? To the back end of the system. And so if there was a priority that we would need to work on for the next 4 years, it's figuring out that funding flexibility, which is really important. And I don't have it right now. And we did a return on investment calculator. We did the study. We built out the social return calculator. Harold is here. He was helpful in our doing that. All great, but how do I make a case to a policymaker that reorder the funding, right? Because you're not going to see the savings for 3-4 years at the back end of the system if we reorder the funding. So from a pure operational perspective, that's a huge challenge. Along the way, we've done all kinds of things, right? We implemented the Affordable Care Act. We worked on homelessness. We eliminated veterans homelessness. We're working on eliminating chronic homelessness, all kinds of things going on in our community. The opioid epidemic, we're dealing with that, behavioral health integration, not having mental health and substance abuse as 2 separate funding streams, but integrating those and integrating the treatment of those. We've worked on early childhood education, age-friendly, according to the World Health Organization standards, and two-generation poverty, just to name a few. So you're not just working on moving the system and integrating the system, you're also at the same time doing program-specific, fund-specific, policy-specific responses. And so now we're coming up at the end of 3 terms of my boss. So what is consuming us is sustainability of all this work that we've done. We don't want a new administration to come in and throw all of it out and start afresh. And so we spend a lot of time in our leadership team talking about how do you bake this into the DNA of this organization? How do we make sure that adoption looks the way we want it to look? And what does analytics really start to tell us? And we've got about a year and a half to build out, use the data now with our new systems and start to tell the story in ways that will ensure sustainability. So that's a huge priority for us going forward.
Thank you very much. So Tom, I know that you're a really practical guy. You've got probably 15 suggestions for each one of our speakers, but I'm wondering if we could ask you to go meta a little bit.
Sure, I
And
can
kind of take
meta.
it up, and then while we wait for you to kind of just reset a little bit, after Tom responds, I'm going to open it up to the audience so that you can ask some questions. We want this to be really interactive. We know that all of you probably have questions for the folks who are up here and maybe some comments. So we're going to expand your role, Tom, but
Sure,
please
that's quite
take it
right,
away.
Margo. And I think pulling a thread out of all the comments is challenging. But what I'm hearing is that every single remark up here was really about sort of a new denominator, a data-driven denominator of the way we're looking at health. Of how much do things cost? 10 years ago was maybe a number plucked out of administrative data that was like a DRG for something. Now we look at cost as this sort of new broad denominator of how much does homelessness cost the state, the country, the county? How much does food insecurity cost? How much does domestic violence cost? Like how much do these other social determinants impact the bottom line? And we're lucky to have payer information here because they could all they can be apolitical in these situations. Like we've looked at the numbers, we know that these interventions save us money. And then I'd even push back on the hepatitis medication argument. I have an opinion. I'm not necessarily pushing back. I guess adding color to it. I'm like, okay, well, Sovaldi is very, very expensive, but it cuts the treatment time in half. It reduces side effects and has a higher compliance rate. So if you look at the denominator of all of the other sort of cost of care, is it too expensive? I have an opinion on that. But I think if you start looking at a denominator that is really inclusive of the entire sort of care continuum, I think you start to have the financial data you need to make the ROI argument. If you're going to design an intervention on homelessness, design an intervention on SNAP, you need that information, and I think that is what we are all articulating. And I'm always impressed with Connecticut because somebody there has a lot of guts to be the headquarters with 72 insurance companies and the largest payer in probably the largest payer in the state does not partner with any insurance carrier. So that's amazingly gutsy on somebody's
A little tidbit to take home.
Yeah, on somebody's part in Connecticut. But I think that's the thread that we are all sort of committed to that. And I think my semi-official comment is that we've sort of moved at ONC from several years ago looking at the noun of health information exchange as we move towards looking at human services, looking at how data really works and how we really can best support Medicaid patients and providers to the verb of health information exchange. Like we really don't care as much about like a health information exchange with walls and a roof as much as we care about data moving. Like if you have one great HIE in your state that can do it all, great, we will support it. But what we are more interested in is just getting data moving. So if we need to move data from one human service to Medicaid, and Medicaid to long-term care systems or substance abuse treatment providers, public health registries of all sorts and shapes and bidirectionality and standalone systems here and there, that are interoperable but are not, an HIE necessarily, then that's what we're moving towards. And I think that's the result of this movement of what will help the states and what will help with addressing that denominator that is so broad and being more and more driven by data and technology and, at the end of the day, finance. So that's sort of where we are and what I think that we're all kind of saying, approaching from different angles.
Absolutely. Thank you very much for tying this together in a very nice way. We are now open for questions. Okay, Martin had his hand up first. So there's the mic. Would you remind everybody who you are? Some people weren't here yesterday and they got a chance to hear you.
Martin Duggan, a member of the board of the Stewards of Change. Yesterday, I made a slightly controversial statement about the options of choice, and I'm going to try hard, but I think I'm going to fail not to raise the blood pressure for Annette. So I'd like to read you something that was I've just lost the page. In a Bloomberg article in September last year. I have to take my glasses off to do this. The price of an EpiPen 2-pack has surged to more than $600 in the US, while in the UK, a similar pair of injectors costs the National Health Service $69. All right, so at what point are we going to have a conversation accelerating progress on the disintermediation that we should be talking about of the middle players, the re-regulation that allows competition to flow, and for people to actually see some of that choice? And the observation I'm making here is you actually have a very inefficient market here in the US for things like that. And when do we start changing that?
And that's not really responsible for the whole U.S. market. Let me just step in as a Kaiser member.
But if I was queen for a day. No, I'm not. Okay. You don't want to know what I have to say if I was queen for a day?
Okay, do you want to answer the question? I know that Kaiser actually has some very unusual purchasing practices. As a member, I know because I've asked my docs about that. So you may want to talk about some of the best practices from the Kaiser perspective.
Yeah. Take a deep breath. No, actually, Kaiser as an organization does have very strong business practices, but that's only 12 million members, and we're confined to our organization. We have very large purchasing power in terms of our contracting. I think after the U.S. government, we're the second largest purchaser of pharmaceuticals, so we're able to leverage much of that. And some of the other things that we're able to do, I think you and I were talking a little bit about direct-to-consumer advertising, but we have a very strong academic detailing and formulary process in which we're able to move market share and control drug use as well as drug pricing. But again, that's just within the confines of 12 million members. So I think the opportunity is really in my colleagues in the state, county, and other programs of leveraging some of the best practices we have, but then working with the federal government in terms of price controls and how to do that. And I agree with you. I think, how do you do that in a free market economy, but then also make it affordable and socially conscious as well?
I think the other health system wants to speak.
So, Martin, great question, and I actually quoted you on Twitter yesterday, so it's now official. So there is a lot of waste out there. A book recommendation is it's a book that just came out called An American Sickness, Elizabeth Rosenthal. So if you've not read the book, go out and buy it. It's really well written, and there's a lot of good detective work that explains a lot of things in terms of how we ended up where we are today. So that's sort of the context. I think in terms of the opportunity at hand and tying it back to the previous panel and the discussions that we're having right now, I think the opportunity, and you asked when, the opportunity and the time is now. I think we've reached I call it an inflection point, where as a nation we're at about $3.x trillion health industry, and one of the things that continues to ramp up is the tremendous amount of waste that exists in the delivery of healthcare. But one of the hopes that I think many of us in the industry have is with some of the changes that could be put in place, and it was really reassuring to hear sort of the common language in the previous panel with the things that we're concerned about at UPMC one of the hopes we have is, how do we really push through that tipping point so that at that inflection point we have an upward swing in terms of actually show by doing, right? Where we're able to really put some of these efforts in place and take the nation to where it needs to be, where we're really focusing in on outcomes, where we're not inundated with bureaucracy, but we're really focused on merit and meritocracy as the new norm, where we're really focused on value-based care, where we're focused on usability and outcomes, and where we're focused on cutting a lot of the bureaucracy out there and increasing the pace of innovation so that we can cut costs and get the United States to where it needs to be in terms of the trajectory that it's already starting to go in.
Kate also wanted to speak to that, the attorney on the panel.
Yes, although I am not an attorney in my job function, I have to give that disclaimer. So I wanted to talk very practically, a couple of threads, because in the absence of unilateral authority to reframe our whole system, we have to say, how do we optimize our participation in it? And from the standpoint of the Medicaid lens, I'd give two examples. One is we have a lot of ability now in Connecticut to look at our claims data and examine it for potentially avoidable complications. So we have a lot more intelligence about which entities, which hospitals, which medical entities are more centers of excellence than others. I would love to be able to point to those entities, and so examining the Medicaid statute and the enabling and inhibiting features there around selective contracting, use of managed care authority around there, I think that's a direction we can go in. And then with respect to the prescription drugs, we certainly have the advantage of being able to leverage rebates in Medicaid, so that's a significant offset to some of the costs. But we have, again, some constraints in the Medicaid statute. One of them is that we were required to cover all FDA-approved drugs, and that approval process has seemed to accelerate greatly in the last several years, with very understandable demands from patient communities. It would be very helpful for us if we could be more selective, if we could apply value-based approaches for prescription drugs. We're looking at, is it possible to do some kind of outcomes-related payment where we would receive a rebate back if there's not the anticipated outcomes? And so when we're in this new environment of flexibility on the part of the CMS leadership, those are the types of specific questions that Medicaid directors are raising, specifically around the inclusion of all FDA drugs and then the value-based payment approaches to try as best to approximate the type of efficiencies that you can get out of a national scheme.
And speaking of CMS, Tom, you look like you're ready to say something.
Well, I do have a tendency to sort of throw out things I've seen work in other states, and I think to Kaiser's approach, that is an option that is on the table for some states, and it's a lever that some states are pulling, which is that the states, you don't always think of a state's maybe Office of Personnel Management as the lever of health policy innovation, but states are huge employers. If you add state employees plus health systems plus universities and contracts that those payers sign with the state or those various systems, they can be in the RFP and in the contracts. We have more and more states looking at, what, we want our payers to to contract. We want better prices for our medications. We want to support interoperability within human services, within health information exchange. We want to use our purchasing power as a state, which a lot of times is something you can do by fiat. Like, you don't necessarily need to do it through regulation or through sort of a lengthy deliberations in the state legislature. You could just sort of, as a state, get together, identify your priorities from the health and human services side and say, you know what, we have a lever over here we have not pulled. And more states are looking to pull that lever as they look at sustainability for some of their health information exchange architecture, as they look at ways to drive down the cost of certain services or use group purchasing. And remember that the ACOs are allowed, per the FTC, to negotiate together as a group. So as you look at these new care models coming out, they have some authority to address some of these things, and it can be an uphill political battle, but it is something that they can do, and more states are sort of getting up the gumption to take on those challenges.
Thanks very much. So I guess the soundbite is find the levers that you haven't pulled yet.
Yeah.
Okay, Richard, you are next up.
Question for Uma. there's been a lot of discussion about the addiction epidemic. Aside from the treatment costs, have you done any review of the impact in your other areas of jurisdiction?
Sure. So our governor's declared, as you know, a state of emergency in Maryland. So we're all living the accelerated interventions, if you will, that the state has asked us to engage in around opioid epidemic. In fact, I was just asking Jonathan, there's an article in the Post today, what are the implications to the Medicare waiver? Maryland's a waiver state of the increased hospitalizations that are resulting as a result of overdoses. Our opioid response team locally is not just law enforcement and corrections and the hospitals and the outpatient treatment providers, the behavioral health community, our schools, because we're seeing increasingly more adolescents who are getting involved in this. And so housing too, so we're really seeing in many ways a multi-system response to, and it's not just opioids, right? Alcohol hasn't gone away. Crack is still in our communities. K2 is still in our communities. We have a lot of other, and then polysubstance abuse is a huge issue, and then it gets complicated with mental health issues and homelessness and everything else. So we have done some work on, with mental health. When we did mental health court and we did drug court, we had to do the cost calculations about what is it going to take. And one of the things we found that the most cost-effective, and I think somebody said in the earlier panel, there are no single sort of evidence-based intervention that this is the only thing that you can use. Different strokes work for different people, and the cost varies, right? Some people need 14-day inpatient, some need 28, some need to actually step down into something else. But one of the things we're finding is that when someone overdoses, and if we're able to send a clinical social worker with law enforcement to the bedside right at that moment, that there is an impact. In terms of, we've seen up to 42% re-engagement in treatment, which is pretty impressive, I think. So we were able to make that cost-benefit case. Now, I can't quote you dollars and cents, but we've done the work to say where is the impacts, and then how are we going to direct our resources towards those particular opportunities.
Have you seen an increase in children being placed in foster care because of
Not
the
in our
addiction?
community. Interestingly, that has not happened. We have seen an increase in our in-home caseload quite a bit, but not in our out-of-home caseload. And part of that, I think, in different communities, we'll see, we're not the highest in the opioid overdose. I mean, we've seen a 400% increase, but it's not the highest in the state. We've done a lot of work on integrated practice over the years with family team meetings, a focus on kinship care, all those kinds of things that have helped to, and we've SDMs, structured decision making. So we do a lot of diversion. I think that has been helpful with the integrated wraparound approach of services.
Thank you very much. I'm glad I live in Montgomery County.
Yeah, we're glad you do too.
Are there other? Yes, thank you. Could you stand and wait for the mic and tell us who you are and where you're from?
Hi. Hello. I'm Ellen Skinner, and I'm a consultant from Connecticut. Thank you, panel, because I think there's a lot of interesting information. One of the things I'm hearing, and I heard it yesterday, and I heard more today, around the baggage created by previous legislation that somehow constrains us or encourages us to carry these policies forward that may or may not be effective today because of what we know about technology and what we've learned. So has anybody thought about any legislation rollback? And related to that also is accountability. So we're doing all of this interoperability, and where does accountability lie? So we heard from the New Jersey law enforcement that they're doing all this work around identifying all these cases, but someone says, well, what are they doing about it? Well, is it really law enforcement's responsibility to take care of that, or do they hand it off to somebody? Who's responsible? Because I do think we're shifting accountabilities here, and how much does the consumer need to take on, how much does the provider need to take on, and who else is responsible? And I leave that open.
Oh, thanks, Ellen. So we have two really big questions. I guess we could break them apart. So who wants to take on the first question?
So I'll start. I think I heard Secretary Hazel raise a point earlier about confidentiality, privacy, and I would say if you want to pick a single policy issue that is really complicated and messy, it would be that, right? So on one end, we're really pushing integration of data, interoperability, and on the other hand, the Office of Civil Rights has actually been ramping up for the past few years breach, prosecution, right? And there's your accountability on one side, and then the actual sort of imperative of sharing data for purposes of integrating and interoperating so that you're improving outcomes for clients, patients, whatever you want to call them. And I think we struggle with that constantly. So we were in the midst of doing this massive deployment of, massive for us, small, very small for all the others at the table, but massive deployment. And right in the midst of that, the Violence Against Women's Act comes out with its new confidentiality privacy requirements. And we had to stop. And we had to see, now what exceptions are we going to make? But if you think about a woman who's experiencing domestic violence, who's about to lose her housing, I can certainly understand the privacy restrictions from her abuser. But then if we cannot share information and we don't know what's happening on the health side, the homelessness side, the income side, the children's side, how are we going to help, right? So I think sometimes that policy question is a really difficult one. And we haven't quite figured it out. I mean, think about this. WIC, this is one of my favorite peeves. WIC, SNAP, and farms. All three are intended to end food insecurity, and we cannot share the data. We cannot share the data, so we don't know which family is getting what, where, and what would it take to, we keep talking about food insecurity in silos, when in fact we should get the full picture and know what is this family eligible for and give it to them. Instead, we send backpack notices for children to let their parents know they may be eligible for SNAP if they already have farms. Well, they should be automatically eligible from one to another if you can make it work, right? So I think there are many policy, we could go on and on about the policy questions, but pick it one at a time. Here we're talking about integration of data, so I think the privacy, confidentiality, and accountability around that, we really need to think through. That's a relatively easy space, right? There is an ACF toolkit in confidentiality and data sharing practices. Some of it is myth busting, but our universities, our academia too, train students to hold on to their data, right? So how do I trust, I'm a social worker by profession, how do I trust that the pharmacist and the nurse and the therapist are going to do their part? I'm the only one who has the competence to care coordinate properly across the system. And how do I let go of that ownership in a way that will, that's the behavior change that everyone was talking about.
Thank you.
Just to add to that a little bit, in terms of policy rollback, and it's a great question, I think one critical opportunity that we have in this inflection point that I was talking about earlier is really focusing or shifting the focus from the debacle of meaningful use and the policies that were related to meaningful use to really focusing more on usability and freeing the data so that we can enable for empowerment of clinicians who are actually providing care, as well as empowerment of patients who are consuming care. And meaningful use, in many ways, it's been good in terms of encouraging the adoption of electronic health records across health systems, and it's increased the number from 7-8% to about 89-90%, which is the positive side. But on the negative side, it's been a game, it's been a sham in terms of how a lot of folks have really been gamifying the system. It's really looking at the numerators and denominators and trying to do just enough to meet the requirements of the carrot and stick that is meaningful use. And just enough healthcare isn't good enough healthcare. And so we need a policy change where we focus not just on just enough healthcare, but really on doing the absolute best and focusing on things like usability and empowerment, which I think are absolutely critical.
Thank you. So we kind of got into your second question, Ellen. Do you want to reframe it based on what you've heard so far?
Yeah, again, I think with this access to data and the leaning towards self-dependency, who do we hold accountable in the process? We talk about gain sharing and whatnot. I do think the dynamics have changed quite a bit, and we do need to hold individuals as much accountable as providers or even insurers to a certain extent.
Well, also, maybe if I could offer a friendly amendment to think not only about the patients in terms of their responsibility, but allowing them, empowering them, engaging them to be able to take care. I had a conversation with Vernon about this last night. So would you like to start on that?
Well, I just had one comment. Yeah, thank you. So in terms of who do we keep accountable, in my mind, it needs to be everyone. All the stakeholders, whether it's payer, provider, patients. And I'll go back to the example of drug companies, and this is sort of the example I'd like to give, is transparency. I mean, I think that's where we're going to be able to keep everyone accountable, and it's in that transparency. You know, from the drug companies, they talk about high drug costs, and most of their costs is in R&D, but I don't think we've seen that data. So that's a piece of transparency. You know, in terms of patients, we've started to give them that information around their labs, their office visit, but we're also working towards open notes, providing them information to what we're writing about them in the health medical record. And it's caused some angst in some people, but why not? I mean, I think so that becomes that transparency piece, and then payer, provider, and so we have a lot of opportunities around being transparent, and it's a careful conversation because, you know, there's some angst to that, but I think that's the future of what we need to do, and that's the next piece of this interoperability, once we have the data, putting it into the hands of people.
Just pretty much what Bruce said in the previous panel. All y'all are holding us all accountable. So Kate, did you want to go next?
Yeah, I think that was beautifully said, and I resonate with that very much. I wanted to build on it by saying, you know, we have a central role in government in synthesizing a lot of different initiatives, and often in a small space. Connecticut's a very small state. We had a lot of concurrently released initiatives under the Affordable Care Act, the Medicare ACO program, health homes, CPCI. You know, the government, I think, is uniquely situated to try to distill out central focus, the aspect of the particular care coordination intervention, the quality metrics associated with it, because we can have that larger worldview. But ultimately, I do feel like I just so resonate with what you talked about, equipping all the actors. And for me, missing pieces are, you know, certainly the data. We are in Connecticut pushing out data, a lot of the claims data, also admissions, discharge, and transfer alerts and the like, and are moving toward the sharing of clinical data with the local practices and systems. But the connective tissue is still missing, the relational connective tissue, particularly with social services. So if there's an expectation around accountability and the interest in associating outcomes with particular interventions, which is it seems to me to be quite difficult, we need much more of that piece. And that's where really our discussions around interoperability are so germane, because that's what makes it actually feasible.
Mm-hmm. So, and that's why it's so important to have a convening like this one, which is kind of a safe space for everybody to share wherever they are on the continuum of the data generation to the data use to the applications. It's really hard to see.
Secretary Hazel's had his hand up
Okay,
for a while.
Secretary Hazel, you're next. Please, go for it. Blinded by the glare, Bill, sorry.
Just listening, and you know, when we talk about the accountability and who's accountable, yes, everybody, but to say that we just have to have transparency, you know, I mean, I know that in my world, I couldn't manage a high deductible plan, not because I couldn't understand it, but because I just don't keep receipts and I don't pay attention to things, and it isn't going to work for me. But it might work very well for her. So, you know, I think the tendency to think in terms of one size fits all is problematic. But I think one of the things I would have gotten to earlier after the last panel is when we talk about markets in healthcare. Now, those of us who come from the Republican persuasion and came in 2010 with the Republican love markets, and we love this invisible hand that he wrote about in 1776. But it requires 4 things to have this theoretical market. It has to have a buyer, a willing buyer, who buys. I mean, and when the government's involved, who is buying? It has to have a willing seller. And as someone who's been in the business of selling services as a physician, I mean, there's clear market inequity. There has to be absolute transparency, of which we have none. Who has gotten a bill from an insurance company, an EOB, in recent history? And who actually understood what it said? The hands go down. There is no transparency. And then the 4th thing are barriers to entry. And everything about the way we've created healthcare, and now even on the social service side and the rehab side, is designed to create towers of excellence, where the higher you climb the academic ladder, the more narrow you become, and there is no communication. So, I mean, to think for a moment we're going to have competition that's meaningful every place. We have places in Virginia where, you know, when 40% of your people are uninsured and the rest are on Medicare and Medicaid, and you have 2 hospital systems, nobody's competing because there's no money to compete for. You can't win. So we have to be able to be flexible to think where competition may work and where it doesn't work as we go through this.
Thank you very much. There was another hand up in the back, and then Charlie, I think, is... And then Charlie, you're next.
Hi, I'm Mary Sarah Jones from IBM, and a question for anyone on the panel willing to address it. On a lot of the health issues that we have, and even a lot of the social determinants of health issues that we're facing today, especially in opioids, homelessness, and some other areas, we tend to take a very reactive approach. And I know that we're creating more and more treatment programs and recovery centers and lots of services, and we're creating essentially like a service infrastructure, if you will. And one of the things I worry about is sometimes when if you build it, they will come. Sometimes it's true. And what will it take, and what is the missing elements that we need to move to more of a preventative approach to get on the front, and not preventative in terms of moving up the spectrum of chronicity. So instead of, we tend to usually stay on the far right. So, and we're trying to move up to the middle now with our risk indicators. How do we get so that it doesn't happen, so that those risk indicators don't even appear?
So thank you. So Secretary, thank you for the question. So Secretary Hazel reminded us that not all markets work like markets, and healthcare is certainly a place to be flexible. And now we're asked about, okay, Kate's already got her hand up.
Yeah, I sincerely appreciate that you asked that question, because I think that all of us want to talk about that more. So in Connecticut, we're following the lead of people who have gone ahead of us in examination of adverse childhood events. That's a kind of key motivator for us in saying there's a very high incidence of adverse childhood events across the population, but particularly so for individuals served by Medicaid. And emerging literature indicates that if we're able to respond with trauma-informed interventions for children at an early point of their lives, we have the opportunity to change the whole paradigm for their adult experience from the standpoint of health, chronic conditions, tobacco dependence, obesity. You know, following that ACEs study, which was, by the way, predominantly middle-class respondents. So it's important to keep that in mind. This is not unique to that tier of the income spectrum, but responding in that way and doing that in a diversionary way, we feel has that impact. And then relationally, the impacts on school readiness and job preparation. And when you could examine that longitudinally, our hypothesis is that that is going to free up resources to focus on more optimal, outcomes for everybody. And that's, something that is of keen concern in a resource-scarce environment. So for us, it's adverse childhood events and those trauma-informed interventions that reverse the self-reinforcing pattern we have often in child welfare of, intervening in an ill-informed way, removing children from their home setting, and exacerbating their trauma by transferring them from setting to setting, often to an institutional setting. And I know that sounds very pejorative, but that's just the facts of what has typically happened historically. And intercepting that, I think, is our single greatest opportunity to reverse some of these adult onset conditions.
Thanks, Kate. Anybody else want to talk about the power of prevention?
Absolutely. I think ACEs and trauma-informed care are the way to go. I think we also need to give ourselves permission to recognize that other things will always interfere, right? So it's like, I use this analogy and it's kind of gross, but it's like the belly of the python. There's already a deer in the belly of the python. If you want to avoid the python from eating other deer, you've got to get upstream, but you still have to put resources downstream because there are too many people who have already experienced harm and trauma, who we need to serve and treat. So every time there is a huge budget reduction exercise, right, the first thing we sacrifice is prevention, because there are people already deeply in need that we need to continue to divert resources to, right? So this is the reality of our world. I think we need to acknowledge that we will never be in a place where we're only paying attention to prevention. We have to do both. And we will continue to do both, and it's the balance that we seek to find at all times. If we could only focus on ACEs and get rid of poverty and all the adverse childhood experiences that kids are, subject to, and we'll get a whole generation that's healthy and well, wouldn't that be awesome? But we're never going to quite be there, because there's going to be harm and trauma that's going to happen, and we're going to have to deal with it at different stages of life. And that's just the world we live in, right? So I don't know that we can ever pivot one way or another. We'll be living in both worlds and being completely schizophrenic at all times.
If I could just add, so true. So not only do I have high blood pressure, but it's schizophrenia as well. But, and it is true, I think we're at a time where we have to have multiple fixes for different scenarios. But one of the things we've been working on at Kaiser is really trying to do some predictive analytics. And we embarked on a project around predicting high utilizers and trying to identify who that 1% will be, and then what are some interventions that we can put in place to at least slow that down a bit as we can. I wish I could tell you we have the Holy Grail, but we don't. We're still on a journey. We have a lot of learnings, but we're still trying to fine-tune that predictive. So who can we identify upstream, at least slow it down as much as we can so it doesn't get to that point.
I mean, I think I would agree that that there is something in the data, but I don't even think that we need something as sophisticated as data analytics when we're talking to, the people at HIMSS or the Silicon Valley. Like, rather than give new wearables for the fit people, like look at the top 10 most expensive Medicaid conditions. Like, start your development there. If you're looking at this in terms of technology, what are you going to do that's going to lower the cost of septicemia by 0.01%, because that will be millions of dollars. Like, that will be an innovation that will work with prevention, that you will get Medicaid attention, you'll get government attention if you're starting to move the needle on these very, very expensive conditions. Preterm labor. If you look again at the top 10 list of Medicaid conditions, a lot of them are psychosocial. A lot of them are very expensive. If there's any innovation out there, I would sort of point your innovation in those areas. Like, septicemia, like an immunization registry can do a lot for, lowering that. And immunization registry costs, probably the best one in the country is $700,000 for a state. Like, that's really not a lot of money for a state. So, like, there's room to make improvements. here that will have significant impact. So there's sort of a margin we can work with, and then the other way to look at prevention is to look at what Uma was discussing, is the sort of the toiling with these various data streams and their lack of connectedness. And what we try to do at Medicaid is we now support what we call onboarding, but you might have known it by something else. Per Rasu's comments about the EHR incentive program, a lot of those complaints were really workflow complaints, right? There were a lot of them were a clinician who walked in the door Monday morning and didn't know what was going on. There's a new EHR. He or she was not involved in the decision making. No one looked at their workflow. We're trying not to repeat those mistakes. We're trying to look at health information exchange and interoperability with this sort of hands-on, someone roll up their sleeves, looking at consent models, looking at business associate agreements, looking at how a clinician might room a patient, does the NP or the PA walk the patient in, take the vitals, how is a quality metrics, what do you click for the numerator, what do you click for the denominator, how do you do it in a way? Because if you look, even back to the Regional Extension Center program, like that, those clinicians were vastly more satisfied than the clinicians who did not have that experience with somebody sort of helping them pick an EHR, think about their workflow, think about their business process modeling. So that's sort of the other aspect of preventive care. Like, you can't build an intervention that connects people to SNAP, that connects people to homelessness, if you sort of don't understand that clinician's referral patterns, if you don't understand the way that clinician practices. So I think that there's those two sort of, one is that the technology innovation, the other is that sort of very messy work of untangling all the sort of non-technical administrative barriers to getting that intervention to happen. So I think that's what we're wrestling with on Medicaid, and we have to attack both of those areas.
Thank you. Maybe we should hear from the Chief Innovation Officer now.
For example.
So I was not going to say anything, and then Tom, you stimulated me, and here we are. So I wanted to add color just from the perspective of, I think, an approach that we really need to be taking. So we've traditionally been taking, and back to the question, really traditionally been taking the approach of, look, go with the tried and tested and status quo, and sometimes we're on the Titanic and we can't see that social determinants of healthcare iceberg that's right in front of us. So how do we take more of a speedboat approach to some of the things that we're doing and talking about here? And part of what I've been trying to push in terms of innovation at UPMC is take a very, and I know we have a lot of colleagues from California here, but take a very Silicon Valley approach to how we reinvent the future of healthcare. So leveraging the principles of design thinking, where empathy and the end user becomes sort of first and foremost in even strategizing before the first single line of code is written, right? And using agile development methodologies. So and part of the success that we've started to see even coming out of UPMC, so it's not just talk but action, is we're risk stratifying, to your earlier point. And we're now discharging patients, chronically ill patients, that are being discharged from our hospitals, not just with a bag of pills and a script that's very difficult to understand, but with technology. And we're monitoring them with their consent. And this knowledge hub that's feeding or collecting all of this data basically informs us that they're about to fall off the guardrails before they fall off the guardrails. We're able to then intervene with care managers and care coordinators and prevent that next readmission and improve the outcomes and satisfaction scores. And it's remarkable, the approach in how we're rethinking this with speedboats and how that is actually ending up in actual results that we can speak of. And I think we need more of that.
Absolutely. Thank you. I promised Charlie. Sorry, Harold.
Thanks, Harold. I hate speaking with people behind my back, so I'm just going to move over here. Hi. I've really enjoyed this conversation so much. I love the level that it's at. I love the questions that are coming. I'd like to sort of take a bit of a change here, so I'm gonna ask my question and then add a few comments to hopefully make some connections. And what I want to appeal to is I feel like we've been looking at history with a 10-year lens on. The past 10 years, I'd like to open that up to the past 20, 25 years. And I'm coming from a public health perspective. So the question that I have for you is, what are the connections that you see here to the work of public health preparedness and the work that was and the federal investments that were made following anthrax, and that changed to the new normal. I mean, now it's not going to add my comments. So there was a time, currently, I think health departments don't even think twice about calling public safety and fire and working with hospitals to do emergency planning and all of that. It's not even a second thought, it just happens. It wasn't always that way. And a lot of that changed with the investments made after 9/11. And I'm particularly thinking of this because the Montgomery County Health Department is here, and you all were an advanced practice center at that time and did a lot of great work in syndromic surveillance and things like that. So I'm thinking about that. The other reason I want to bring up public health emergencies, public health preparedness, and its connection to investments made by HRSA into the healthcare system and the current work of ASPR. So there's a couple other connections. But the other reason I'm thinking about it is this is a past thing that's happened. It's something that's continually received fewer and fewer dollars from the federal government. But yet, it strikes me that we're here talking about an emergency. We're talking about interoperability, and let's just be honest, interoperability is both the sharing of data, the act, and it's the relationships. You can't have one without the other. You have to have both, the act and the relationships. And preparedness is about relationships at its base. So I'm wondering what your thoughts are with the connection between what we're faced with today to the infrastructure and the capacities that are in place from public health preparedness, maybe lessons learned from that experience that we shouldn't repeat, that kind of thing. So I'm wondering what your thoughts are about the connections.
Let me just say that we're actually going to have a conversation about that this afternoon in the last session. Thank you for raising the issue. We have 4 minutes left, so I'm going to give everybody one sentence to respond to this very big question about what do we do about the infrastructure that we built and how do we tie together a lot of what we've already done to what we're going to do in the future.
Well, I can do one sentence. It's really new relationships. I think for us, it's really been looking up and looking out the window and see who we can partner with.
There's some people out there.
I'm gonna go out and talk to them.
Kate, you want to?
We can, so one sentence is, for us in Medicaid, CMS was an incredibly important catalytic to this process under the state innovation model in incorporating in the later rounds of procurement for that opportunity for states, a very strong emphasis on the nexus to public health. And so that is not only capitalized through federal grant funds, but also essentially pointed the federal policy direction in that area in an enabling way. So that's really a central seat of our model test grant in Connecticut.
So to me, both data sharing, relationships, all of them are iterative. And what we've learned from our experiences to date have driven further improvements, if you will, in the process. And so that has to continue.
In the one sentence, I'd go back to that inflection point that I was talking about earlier, and the opportunity at hand really is to, when you think about regulations, to sort of right-size the throttle that those regulations have, and veer towards perhaps even deregulation to increase the speed of innovation. I think the pace of innovation needs to be increased, and regulations has a lot to do with it, and that's a tremendous opportunity today.
So, my one sentence.
Last word.
With several semicolons. So, Medicaid systems can support emergency systems. We're connecting EMS to HIE in California. We're building a Zika registry in Puerto Rico. We're talking to various states that want to build sort of emergency management systems based off the Pulse system in California that sort of does on-the-fly enrollment in a disaster. And so it's something that we can support and that we are supporting, and it always takes a certain level of engagement from the state Medicaid agency. But if the state wants to build it, we can talk and we can see what we can do to use Medicaid systems to support your priorities.
Thank you very much. Please join me in thanking this great